what we're going to go ahead and do is just mute everybody just to try and minimize any background noise. If you have a question or something comes up, if you can just type something in the chat, Jim will be watching to kind of keep track of who has questions. I did get some questions in advance, and I've incorporated those already into the slides. So if you do have a question, it's possible it might end up being answered already, but we'll have time, as much time as people want after the slides. We're going to be talking about COVID-19. For those of you who might not know me well, was an emergency medicine doctor for 13 years and had to retire because of my own medical issues. So it's been years since I've taken care of patients, and I've not taken care of any COVID patients directly. But throughout my career, infectious disease and epidemiology were areas of interest for me. So this was something I was tracking back in January and continued to pay close attention to for obvious reasons. Oh no, it's not letting me do my slides. There we go. First of all, I just want to acknowledge we've lost more than 500,000 Americans to this disease. And if you're someone who has lost someone who's dear to you, you have my condolences. And all of you have my thanks, because your willingness to be here and participate today means you want to be informed and you want to be part of the solution and bringing an end to all of this misery. So thank you for coming. We're going to go over some basics, a couple of definitions, just so you can sound super smart when you're talking about this with anyone. And then the science of what we know about COVID. I'm going to focus, as I said in my announcement, mainly on the variants and on vaccines, since both of those are top of mind, and those are really where we determine our future at this point. I'm going to review some other issues around public health besides vaccination. And then, like I said, there'll be time for questions. So a couple basic definitions. So the virus that we're talking about is actually called SARS-CoV-2. That's its official name. It was first identified in 2019 in Wuhan, China, and it was formerly called the 2009 novel coronavirus. So you'll remember a year ago we were talking about the novel coronavirus, SARS-CoV-2. And it got this name because it shares characteristics with the original SARS virus that was discovered earlier in China in 2003. And at that point, we didn't have a huge world pandemic, and there were a total of about 8,500 cases. But the fatality rate with SARS, the first time around with SARS-1, was 11%. 1 in 9 people who got the SARS virus died of it. Fortunately, this one is not nearly as severe. And COVID-19 is the disease that's caused by the virus. I'm going to be using COVID-19 as sort of the catch name. But technically, it really only is the disease, not the actual virus itself. Okay, what's a mutation? A mutation is just an error. In viral RNA, it gets copied to make proteins. And if G is typed in instead of an A, then an error happens. And that's what a mutation is. A variant, it would be then a new version of the virus that contains one or more mutations from the parent virus, the original virus. So anything that's off is called a variant. If the new version of the virus has an actual structural difference from the parent virus, then it's called a strain, a viral strain. And we talk about strains with regard to influenza and flu. So when we get our flu vaccinations every year, those vaccinations include multiple strains so that it's reactive against all of what's thought to be circulating. For the purposes of talking about SARS-CoV-2 and COVID-19, the easiest thing is to talk about variants. And so if you want to be correct when you're talking about any of these unusual versions of the virus, saying the word variant qualifies. Everything's a variant. Some strains have structural difference, but strains are also just a different variant. So variant, variant, variant. We talk about isolation and quarantine. Technically, isolation is if you're confining someone who has known disease. I test positive for COVID, I go into isolation. Quarantine is confinement if you're someone who's had close contact to someone who's been infected. So quarantine is a preventive measure, ideally. All right, so let's talk about some of the science. Let's talk about variants. They're top of mind. It's what the conversation was about before we officially got started. There are a few different ones that are important. And let's talk about how they become important. So mutations cause new variants. They're random. Any different random mutation can happen. Some of those mutations end up being lethal to the virus, or they prevent it from further propagating. So we never even know about those mutations. Some of them can give the virus new or enhanced traits. These are the ones we have interest in and the ones we sometimes have concern about. The ones that are particularly concerning traits are if it makes the virus more transmittable and more infectious, or if it causes more severe disease and higher death rate, or if it allows the virus to somehow evade our normal immune protection. And so what you'll hear is that there'll be talk of a variant of concern. That means it has one of these characteristics, or it's thought it might have one of these characteristics at the bottom. So what are the current variants of concern? The one that came up just in conversation beforehand, B117, sometimes called also the UK variant. It's not proper to call it the UK variant. There are some political issues around that, but it's hard to remember B117. So a lot of people call it the UK variant, and that's understandable. Also the one originating in South Africa, the B1351, and then the one originating in Brazil, P1. So these are the technical names, B117, B1351, and P1. So of course, the biggie that everybody's concerned about most is B117. So let's talk about the characteristics of that variant. It is definitely more transmissible, and the best estimates are that it's somewhere between 40 to 60% more transmissible than the non-variants. It does also appear to cause more severe disease and a higher death rate. Both of these things are bad news, clearly. On the positive side, the original variant does not appear to affect immunity. So the vaccines do work as well against the original B117 as they do against the non-variant type. But there has now developed a secondary subtype that has also acquired the mutation E484K, that's called EEK. And because that variant has obtained that, it may be able to evade immunity. And I don't know how many of you heard this in the news or read this in the news, that one of the B117 variants was discovered here in Portland, and it's the one containing this EEK variation. So yeah, variants are a big deal, and they can cross match. So they can, any interaction with a variant and a regular virus can cause different combinations of mutations. More about the variant. It's currently the dominant strain throughout the UK. It's growing in prevalence throughout the US. I looked at the numbers as of Friday. We have about 3,700 cases across 50 states and jurisdictions, so it's very widespread. The largest number of cases is in Florida, 690 in Florida, then Michigan, and then California. It's important to know, as we're talking about what our numbers are in our own country, that the United States sequences only 1% of its cases, where some of the European countries are more like 10% or 30%, even higher. The other important piece here is that sequencing process takes 30 days. So whatever we have sequencing results from is actually from a month ago. So it's important to know that. The cases here in the United States of the B117 variant seem to be doubling every 10 days. In order for that variant to become dominant, the critical number is 50%. And given the current rate of doubling and higher transmissibility, the surge related to this variant in our country is expected by the end of this month. In Florida right now, the B117 variant makes up 40% of their cases. So they are very close to achieving critical mass. And it's unfortunate timing because, of course, spring break's coming up. And we expect as different areas are opening up their businesses and cultures and societies a little more, relaxing their COVID restrictions, it's going to give people confidence. It's going to allow travel. So really, Florida is our canary in a coal mine. What happens in Florida is what we can expect in the rest of the country. Let's talk about the other two. The South African variant, B1351, it does appear that it is also more transmissible. It does not appear to cause more severe illness, which is good. And it does appear to affect immunity, meaning that vaccines might not be quite as capable against this as the other variants. It's not established dominance in any other country, including the US, but it is documented here. We have, as of Friday, that we have 108 cases across 23 states or jurisdictions. And then the third one, the Brazil variant, very similar to the B1351. It does appear to be more transmissible, does not seem to cause more severe disease, and it does appear that it's better able to evade immunity. And when I say any of these can better evade immunity, that means anyone who has natural immunity from having had COVID or anyone who's had a vaccine against COVID. It affects both of those, makes those less likely to be protective. This caused a devastating outbreak in Manaus, Brazil. They were really just devastated by it. And it's been, like the B1351, documented in many countries, including a case here in Oregon, but it has not established dominance anywhere else. So really the biggest by volume is the B117. I think as of Friday, we have about 17 cases of the P1 virus in the United States. There are a couple of domestic variants I want to mention, and they're currently considered variants of interest. Okay, so variants of concern is a problem. That means we know there's an issue with it. Variants of interest means there's some traits that are involved that may or may not be problems, so we're going to watch them. One came from California, and it's called either B1427 or B1429. We don't know yet if that is more transmissible or produces more severe disease. That's being studied, and we'll know as the numbers get better. The other is from New York. It's called B1526. And the reason this is of interest currently is that it has one subtype that might affect immunity. And so that's being watched as well. So what do? Let's get our vaccines. Let's talk about it. We have 3 of them that are currently approved in our country, in the United States, under EUA, which stands for Emergency Use Authorization. So this is not the intense, detailed, lengthy process that happens when, for instance, the flu vaccine comes out. This is something that we're using under emergency use because we desperately need it. There are 3 of them, as I said, Pfizer, BioNTech, Moderna, and Johnson & Johnson. We'll talk about each of these and what their structure is and how they work. So first, let's talk about the mRNA mechanism. This is the mechanism that the Pfizer vaccine and the Moderna vaccine use. The vaccine itself consists of isolated fragments of messenger RNA that are encased and suspended in fat or oil droplets. After the injection, those droplets are taken up by the cells and come into the body of the cell. And then that protein, the messenger RNA, triggers the manufacturing by the cell of the SARS-CoV-2 spike protein. So what it does is it tells your little protein factory to make these little spike proteins. Once those proteins are there, your immune system learns how to recognize it and how to attack it because it's immediately recognized as foreign and not belonging to your body. The SARS-CoV-2 virus is not in the vaccine, so this vaccine cannot make you sick. The viral messenger RNA that gets brought into the cell stays in the body of the cell only, and our own DNA remains enclosed in the nucleus, the center of the cell. So there is absolutely no interaction between the viral messenger RNA and our own DNA. I know that's a concern that some people have heard about, can this affect our DNA and affect our genetic code? And it has no contact with that and does not affect it. And immediately after that messenger RNA is used by the cell to produce the proteins, it's destroyed. So it is not something that stays in your system. It's temporary. Let's talk about manufacturing and distribution. It does not include cell cultures, and that's because it's just using snippets of protein encased in oil. Because cultures aren't needed and that process doesn't have to happen, manufacturing is actually more rapid than with a lot of other vaccines. At the same time, the trade-off is that it also requires more careful handling. And this is where that deep freeze comes in. These have to be maintained at a very cold temperature in special freezers. So ultra low temperatures for transport and for storage until shortly before use of it. And it also requires a second booster dose. A lot of you have already had your doses, so you know that these are 2 shots. Let's talk about the other mechanisms. We talked about messenger RNA, mRNA mechanism. Now we'll talk about DNA mechanism. This is Johnson & Johnson. In this one, the viral messenger RNA is spliced into the DNA of a carrier virus of a different kind. After the carrier virus goes into the cell, the viral mRNA then triggers the protein manufacturing. And again, it manufactures that SARS-CoV-2 spike protein, the little spike protein that it sees. And just like with the other vaccines, this is then recognized and attacked by the immune system. The carrier virus that is used for this is adenovirus that's lab inactivated. Adenovirus is a very common type of virus that causes the common cold. It's something that we're exposed to frequently. And the carrier virus is inactivated by the lab, so it can't cause disease. So this also cannot cause disease when it's used. And as in the messenger RNA vaccine mechanism, this also does not have any interaction with our own DNA. And the messenger RNA is destroyed immediately after the spike protein is manufactured. So how is the manufacture and transport of this one different? Well, this one does require the use of cell cultures. They take the virus that's inactivated and has the messenger RNA spliced into it. Then they inject it into eggs and culture it to form a colony of virus to then be used in vaccines. So because this takes time, the manufacturing takes longer. And this is exactly why the minute this was approved, we didn't have a flood of hundreds of millions of doses. It's why it's taking longer for us to produce and acquire Johnson & Johnson doses. And in fact, in case some of you haven't heard this, this is also a great example of a good use of the Defense Production Act. The president decided that we needed to up production of this one because the production is more difficult. And Merck Pharmaceuticals had actually abandoned a vaccine that they were pursuing because it had failed. So the president asked Merck to start manufacturing this vaccine produced by Johnson & Johnson. So we actually have 2 different pharmaceutical companies collaborating and producing a vaccine that's only owned by one of them, which is excellent. The trade-off on the plus side is that manufacturing takes longer, but the components are more stable. So the only refrigeration is needed for transport and storage of this vaccine. So the Johnson & Johnson is much easier to transport, much easier to store, and much more forgiving when it comes to timing the doses and not risking wasting doses. And the big bonus, only 1 injection is needed, which is another huge advantage. All right, so let's talk about efficacy. This is the other big point that can be confusing, but is important to understand. So first, as the vaccines are being developed, they get successfully tested in a smaller group to make sure they're safe. That's the first step after they're made. And if they pass that, then they go to their efficacy trials. And for the efficacy trials, you have thousands of volunteers. I think between the 3 vaccines that we're currently using, I think there were something like 85,000 volunteers altogether testing them for efficacy. By random selection, half take vaccine and half get a placebo injection. Everybody gets an injection, just half of them get vaccine, half get placebo. And then both groups are followed over a period of time, and all data regarding any side effects, any infections, how severe the disease is, whether people die, and if any other significant clinical events happen, all of that is recorded and analyzed for both of the groups. And then efficacy is a calculation of how much reduced risk there is for a measured outcome in a vaccinated group compared to a placebo group. And I'm going to show you an actual example. In trials of COVID-19 vaccines, this is a question I've received multiple times, not just from our group at church. The measured outcome is clinical infection, which means symptomatic infection. So what they measured was starting at day 28, from that point forward, how many people had symptoms of COVID and then got tested and found out they had COVID. So here's a calculation example. The numbers won't work perfectly because I've adjusted them a bit to make it easier math. So let's say 5,000 volunteers get placebo, and of those 5,000, 63 get COVID. And then the other 5,000 volunteers get vaccine, and only 18 of them get COVID. The difference between the two groups is 45 cases of COVID infection. And then that means 45 of the 63 expected, because if we did nothing, just like placebo, we think about 63 would get it. 45 out of 63 are prevented. 45 divided by 63 times 100 is 72% of efficacy. So people see the 72% or 94%, and it's easy to think in your head, oh, that means 6% get COVID. That's not at all the case. You can see here, even in the untreated group, only 63 out of 5,000 got infections. And so the numbers of your individual risk are much, much, much smaller. And let's do the second example. This is another example. It's another way you can look at efficacy. Let's say those 5,000 volunteers got placebo and 9 of them got severe disease. And in the vaccine group, only 1 got severe disease. Then we can do the same type of calculation. 8 of the 9 severe infections were prevented. 8 divided by 9 times 100 means 86% of efficacy against severe disease. Again, the numbers don't work because I made the math easier by adjusting the numbers. So what's the efficacy of the vaccines we have? Pfizer is 95% effective against clinical infection. Moderna, we think, is 94%. And Johnson & Johnson in our country is 72% effective. And that first calculation that I showed you is Johnson & Johnson. Both of those examples that I used were the numbers for Johnson & Johnson in the United States. So again, this is clinical infection. Anyone who has symptoms and knows and then finds out they have COVID, 72% of those cases are prevented. Instead of 63 people out of 5,000 getting COVID, only 18 people out of 5,000 get COVID. And just by comparison, I think this is important. An annual influenza vaccination is typically 40 to 70% effective. So all 3 of these vaccines are extremely effective. When the Operation Warp Speed was being set up to start with, the threshold that companies had to achieve was 40% efficacy. So these numbers are fantastic. They are all excellent vaccines. We're lucky. And let's talk about severe infection for all 3. Pfizer is 100% effective against severe infection. Moderna is 100% effective against severe infection. And Johnson & Johnson is 86% effective. So just like I said in that example, only 1 person out of 5,000 had severe infection in the Johnson & Johnson group. So very tiny, tiny numbers. What about death? All 3 vaccines had 100% efficacy against death from COVID. Anyone who got a vaccine, or I should say it the other way around, no one who got a vaccine died of COVID. So again, this is all really good news. Should give us all confidence. So we know the vaccines are good. We know we want them. What do we need to do? Well, people ask a lot, which vaccine should I get? And the very clear answer that every infectious disease doctor I've ever heard talk about it says whichever one you can get the quickest. And I know a lot of people have some hesitance about the Johnson & Johnson because the numbers are lower. But there's something interesting to consider. Because it's only a single dose injection, you actually achieve immunity faster by getting the Johnson & Johnson dose, meaning you get your injection and then 14 days later, you're fully immune. Where with the ones that require 2 doses, the Moderna and the Pfizer, you get an initial vaccine, you get another one in 3 or 4 weeks, and then 2 weeks after that, you achieve full immunity. So really, this all adds up to you should feel comfortable and excited to get whatever vaccine you can get the quickest. There, you will be protected well by any of them. There's one exception. If you happen to have a personal history of blood clots, it's best for now to avoid the Johnson & Johnson. And that is only because in the groups they studied, there was a slightly higher risk or slightly higher incidence of blood clots discovered in patients who got the vaccine compared to placebo. We will know more as the numbers get bigger about whether that is a specific concern we need to consider in deciding who gets what, and it's being monitored. But I would say, I think just out of an abundance of caution, if you are someone who has a history of blood clots, I would avoid the Johnson & Johnson until you hear otherwise. Where can I get a COVID vaccination? That's the other big question. I think we're all becoming very versed in this. There's a drive-through site at PDX. There's a walk-up or wheelchair use site at Oregon Convention Center. And then there are local pharmacies that are participating: Albertson, Safeway, Fred Meyer, Costco, Walgreens, and Health Mart Pharmacy family. What can I expect at time of vaccination? You'll be asked for your identification and your medical insurance, so you should bring your ID and your medical card. You will be asked a lot of questions about allergies and allergic reactions. And the medical consent process might feel a little more intense than what you remember from other vaccinations. And that's because, like we said at the beginning, these are being administered under an emergency use authorization, which means there hasn't been the length of time and the giant numbers to make this fully approved by the FDA. So they have to maybe give people a little more information and explaining that a little better. So that should not dissuade you. That's just part of how the structure is right now. What else? You will not be asked for any payment. So you should not have to worry about that. You will be asked for your medical information, your medical insurance information, but you will not be asked for payment. Most places, this is not for sure everywhere, but most places you will be offered an appointment for the second dose if one is needed. And at any of them, you will be given a vaccination card that you should bring to your next appointment. After the injection, you will be observed for at least 15 minutes, possibly longer, possibly 30. And that's just to watch for allergic reactions. The other thing that's going to happen at your first appointment is you'll be offered a chance to participate in something called vSafe. It's a program administered by the CDC. And it's a smartphone health-based monitoring system that uses texts and surveys. So it'll send you questions and surveys, and it allows you to report side effects or complications. And it also allows the CDC then to gather that information. If they see any of your information that's concerning or that they want more information about, they might call you about that. It will also help send you a reminder for your second dose if that's needed. And the more people that participate in this means the better the information is moving forward. As of about a week ago, there were at least 4 million people participating across the country. So I encourage anyone who feels comfortable doing that. It's helpful. It's the way we start getting all those numbers to be able to understand exactly all the detail about these vaccines. What about after your vaccination? People are concerned about side effects, which is legitimate. And they usually start 6 to 24 hours after injection. The most common are pain at the site, arm pain, arm swelling. You can also have headaches, fever, chills, muscle aches, fatigue, any of these things. The side effects are definitely more common after your second injection. And depending on what your situation is and what your work situation is, you might want to be mindful of that as you schedule your injections. That's why a lot of workplaces are trying to stagger their employees so that the employees won't all have side effects at the same time. So for instance, if you're a single parent and you're taking care of your children, you might try and schedule your second appointment at a time when you know you can have help with childcare, for example. And the other good news is side effects are less common in older adults. The older you are, the less likely you are to have side effects. So that's helpful. If you do have pain and fever and want to take something over the counter, it's best if you can to take Tylenol or acetaminophen. There's concern that taking any of the anti-inflammatory medicines like ibuprofen or Motrin or Aleve or naproxen, there's a chance that they might slightly decrease how well your body reacts to the immune. You're not going to harm yourself by taking them. And if you've already taken them, that's fine. But if in advance you know that, better to go ahead and go with Tylenol if you can, just to be even safer. What about severe reactions? This is the other concern that people have that's completely legitimate. Severe reactions or anaphylaxis, that's the other medical name for it, to COVID mRNA vaccines have occurred. They have not been very common. They've been rare. For the Pfizer, BioNTech, it's only been 5 in 1 million. And for the Mrna, even less, 2.8 in 1 million. When severe reactions happen, they can have an onset anywhere between 2 minutes or 150 minutes. The average is 13 minutes, that's usually, which is where that 15 to 30 minutes observation period comes from. They want you to be watched long enough so that they can know if you're likely to have a severe reaction. And if you do have a severe reaction or anaphylaxis, there is medication there. At any of the injection locations, they have those medications on hand because they're prepared for this possibility. And for comparison, when people get flu injections, the risk of the severe reactions or the rate of severe reactions and anaphylaxis after flu injection has been more about 1.3 per million. So this is higher than flu, you know, two to three times higher than flu, but still very small, 5 in 1 million. But it is also why you'll be asked a lot about allergies and allergic reactions. That's why you see so much of that on the paperwork when you get your injection. What about deaths after injection? I got a question about this. The CDC receives reports of deaths for any cause among people who have received a COVID-19 vaccine. And all of those reports are reviewed by a CDC or an FDA physician, and then that's tracked. And so far, there is no apparent link found between COVID vaccination and deaths. And that's also been true in the countries of Norway and Germany. So there's not any indication that we think there's any increased death rate among anyone who's had a COVID vaccine. So let's talk about this too. We talk about our own vaccinations. We talk about vaccinating other countries. And yes, it's our ethical obligation, especially as Christians. Here's the important thing though, it's a strategic imperative. People who are unvaccinated can be sick with COVID, and people who can be sick with COVID can be breeding factories for more variants. And so the longer this becomes an active infection and people are available to be infected by it, the higher the risk that we develop more and more variants and more difficult variants with regard to our own vaccination. So this is huge. It's really important that we ensure that everyone across the globe gets vaccines as safely and as quickly as possible. So let's talk about the other things we can do besides vaccines. It may not be your turn yet. It's not my turn yet. And so these are the things I remind myself of too. COVID-19 is a respiratory illness. So all of the preventive measures we take are focused on minimizing our respiratory exposure. And so one of the infectious disease doctors I follow that I like a lot talks of it as air swapping. So someone who has COVID breathes out air with COVID in it, someone else breathes it in, and if enough COVID is in the air that you breathe in, you become infected with it. So we keep our distance from each other, we wear masks around each other, and we avoid sharing enclosed spaces, especially if they're poorly ventilated. So I do want to share some information about masks. And let me be clear, it's really important that we continue to use them for as long as we need to. But a very recent study of different mask types was done by the research arm of OSHA. And then calculations were done by an infectious disease group. And they looked at the leakage of particles of this size, 0.6 to 1 microgram in size, on different mask types. And this is the size of aerosol. So this is the size where things are passed to each other. So an inward leakage. So if I'm wearing a mask, how much air comes to me even though I'm wearing a mask. So high numbers are bad, inward leakage. If I'm wearing an N95%, only 1% of the air actually is going to get past the mask and into me. If I'm wearing a surgical procedure mask, those are the little kind of blue paper ones that have the bendy nose, about 40% of the air will leak around and I'll be exposed to it. If I use a 3-layer cloth mask, it's higher, about 77% of air does leak around and is going to come expose me. Interestingly, a 1-layer neck gaiter, those are the ones that kind of come all the way down to the chest, was a little better, 59% leakage. But you can see from these that masks are not perfect. It's important to wear them and they help. I heard someone make the analogy that it's kind of like a seatbelt. Seatbelt, it's important for you to wear your seatbelt in a car crash and it will prevent some deaths, but we also need anti-lock braking systems. We also need airbags and collapsible frames that protect the driver. So it's an important tool, but I share this because I want people to understand it's not a perfect tool. So we still need to be careful about our exposure even when we're masked. And what about the outward? Outward is how much of my air gets out to the world and potentially could infect others. Very similar, N95s is only 1%. Procedure mask, surgical procedure mask is 52%, about half. 3-layer cloth mask is decent, 61% still gets out though, and the neck gaiter also 61%. So very much the same thing. It works both ways. It's helpful, but it's not the end all be all, especially if you're waiting for your turn for vaccination. What about quarantine? CDC guidelines, if you've had close contact, and so what is close contact? If you are within 6 feet of someone for a period of 15 minutes or more, cumulatively within a 24-hour period, that's considered close contact. So for instance, if you have a coworker in the office where you work and you spend 5 minutes sitting together and looking at paperwork together, and you do that 3 times in one day, you are a close contact of that person. And so this is another way that we prevent infection. So if you have had close contact with someone who has COVID or discovers they have COVID, you should quarantine for 14 days, and it helps minimize how much further the chain of infection goes. The first day of quarantine is your last day of exposure. And there's been some talk, I didn't include the details here because it is a little complicated, but local health officials can lift quarantine a little earlier than 14 days in certain situations. We can talk about that. If you want to hear that, you could ask for the question and we'll talk about it more when I get through the last slide here. There are also some interesting changes now that people are getting vaccinated, that quarantine after close contact is not required in some cases. If the person who is potentially exposed themselves had a documented case of COVID during the past 90 days, that means they're fully immune, and so they do not need to quarantine. And likewise, if the exposed person's final COVID vaccination happened 14 to 90 days ago, that person's also considered fully immune. It does not need to quarantine if they're exposed. The other way we prevent is if, God forbid, we get COVID, we isolate, which means we need to stay separate from other people for 10 days and until fever-free for 24 hours and symptoms are improving. If you're someone who unfortunately tests positive and is sick enough to need hospital care, that's 20 days plus fever-free for 24 hours plus symptoms improving. And for counting, the first day of isolation is either the day your symptoms begin or the day you have a positive test if you happen to be asymptomatic. All right, these are just some basic resources. They're the resources I used in putting this information together, and they're the ones I look to. Oregon Health Authority, of course, has local information. Centers for Disease Control and Prevention has national level. The New York Times has really superb coronavirus coverage. They have detailed portfolios about variants and how vaccines work and diagrams to explain that, trackers, case tracking. So there's plenty to see if you want to look at that. If you are at all a science nerd like I am and you want more detailed information, then I really recommend the Center for Infectious Disease Research and Policy, or CIDRAP. They're located at the University of Minnesota in Minneapolis. And the director of their center, Dr. Michael Osterholm, has an excellent weekly podcast about COVID-19. It usually posts every Thursday. I listen to it every Thursday. It's about an hour. He does a very good job of presenting the information in a very practical way with a good level of detail, but also focuses on the human part of this whole experience too. All right, I'm going to go through some questions that I got in advance of putting this together, and then we'll open things up for questions from all of you all. So first question, should I be concerned about getting the vaccine if I have high blood pressure? No, high blood pressure does not affect the safety of vaccination. So that's good news. That's not a concern you need to worry about in terms of getting your vaccination or which vaccination you get. Another question. My doctor told me I can't take live vaccines. Which COVID vaccines can I take? It's another one with good news. You can take all of them. All 3 of them are safe. None of the 3 vaccines that we have currently approved are live vaccines. If at a future time there ends up being some development of a nasal spray, like there is for flu, that's one you would need to check about your doctor with. Usually the nasal sprays are considered live attenuated, but for now the injectables completely safe, no problem. This one is a little tricky, right? How far in advance can I schedule my first vaccination? This is a tough one. Scheduling the appointment, first of all, is only allowed once you are actually eligible. So even though, for instance, my group should be eligible March 29th, if it were another type of an appointment, I would go a week or 2 ahead of time and try to schedule my appointment for the 29th or soon after. Unfortunately, the way the systems are currently set up, you have to already be eligible to even go through the scheduling process. The other end of that, the back end of that, is that they aren't scheduling things terribly far ahead because it's important for them to know how much vaccine they actually will have on hand so that they can administer it to everyone who comes. So I think most places are only scheduling them maybe a week in advance, but that may change with time as we have more and more doses. That may become a little looser and easier. Are statistics being kept on vaccine side effects and reactions? Yes, not just through that V-Safe program I talked about. And the other part was, do doctors have access to the information? And all of this is yes. So this information is tracked by the CDC. Anyone who wants to can go onto the cdc.gov website and see some of this information. And then if a significant or serious issue comes up, doctors receive notification. There's something called a black box warning that can happen. So if for instance, some particular event, I'll make it sound silly so it doesn't sound like that's actually happening. If we found out that one particular vaccine was turning people's skin purple, then they could put out something called a black box warning saying that this particular vaccine is causing issues and use of it should be suspended. So yes, the short answer is yes. This is the big one. How soon is it safe to socialize after getting vaccinated? 14 days. The official is 14 days after the final vaccination. If you are getting a vaccine that requires 2 doses, you do gain some immunity after that first dose, but you're not considered fully immunized until 14 days after your final dose. Another big one, do I need to keep wearing a mask if I am vaccinated? In public, yes. In private, if you're socializing with other people and everyone's vaccinated, no, you're fine, go for it. There's also one other possibility. If you are allowed to have a maskless visit, if you are visiting people from a low-risk household, excuse me, let me back up. You are allowed to have a maskless visit if you are visiting with people who are low risk, even if they're unvaccinated, as long as they're from a single household. The practical application of this would be vaccinated grandparents can visit unvaccinated grandchildren, as long as it's from one household. Or like in my case, a lot of my friends are older, they've all been vaccinated. I've not been vaccinated. If I were low risk, interacting with a bunch of people who've been vaccinated, then that would be acceptable. All right, thank you. Those are the questions I have so far. I'm going to get out of here and I'm going to stop my screen share. And we can, oh, good, we've got chats. That means we've got questions.
Okay. Amy, if you want to go through the chats, that's fine. Otherwise, I can give you the questions, however you want to do that. I would ask everybody else, at least for the moment, to stay muted.
Sure. Let me look at the chats here. I've got them up. Okay.
So it starts with
George, yeah, 30 days to sequence is way longer than it should take. Yeah, I know. I don't know enough detail about the scientific process. I'm sure you know much more than I do, but my understanding is that it's a process thing. It's not an issue with like getting the sample or acquiring the sample. It has to do with it having to be amplified first, and so it's a technical factor. But yeah, it makes it difficult. We're sort of chasing the tail of the dragon. Ray Richin, if you have autoimmune disease, what is the reaction to the shot? It's a good question, and I actually just attended a webcast about this a week or two ago. It does not seem that patients with autoimmune diseases have any significant difference in how severe or how common their side effects will be. It's kind of neutral on that. It also, the other good news is that getting the injection itself does not seem to be a trigger. So it doesn't in and of itself trigger autoimmune symptoms. But for instance, I have a friend who has multiple sclerosis, and she tends to manifest her symptoms more if her body temperature is higher. So for instance, if she got her vaccine, spiked a fever because of having a side effect, that might trigger her MS symptoms. But it's not likely to cause a flare of an autoimmune process. I hope that made sense. Next question. Does the vaccine have a negative impact on cancer treatment, chemo, or immunologic? Does cancer treatment minimize efficacy? I read today that the Pfizer is not as effective for cancer folks after the first shot. This one I don't know a lot about. I don't want to pretend I know something I don't. It definitely, I do know for sure that people who are getting cancer treatment are recommended to get the vaccine, and they're actually considered to be in the highest risk group, and should be, if they don't already have a vaccination because of their age, that they should be the next group to get vaccinated. I can get back to who, you could tell me who that, I'm not sure who that actually is. Is that you, Jim? That's Rose City
It's
Sessions?
me.
No.
It's me, Karen.
Oh, Karen, good. Yeah, I can look into that for you, Karen. I'm going to make myself a note. I'll look into it and I'll get back to you on that. I'll email you.
Thank you.
So let's say cancer, negative effect on chemo, and then, or different efficacy. Okay, I'll check that out for you. Okay, George Johnson. Oh, thank you, George. Yeah, another side effect is swelling of lymph nodes on the injection site noted from mammogram data. Thank you. Yeah, that's completely legit, and that happens because the site of the injection is, of course, where you're having a stronger reaction, and your lymph nodes are kind of your immunologic little factories. So if they start getting busy, they get swollen. So that's a good point. Let's see. You've talked about antibody protection. How important is a T cell response in preventing infection? Yeah, I did that. I spoke only about the antibody protection on purpose, just because, yes, there are finer points, but it's less well understood because it's harder for us to have monitored it. So I'm punting on that one. And then Rosie Session, difference between N95 and KN95. Yes, there is a difference between N95 and KN95. The difference is where they are manufactured and whether they have gone through OSHA or NIOSH validation. They should be equally effective, but this is unfortunately a bit of a can of worms because unfortunately there have been fraudulent, what am I trying to say? People have been trying to sell masks as KN95s that aren't really KN95. I'll get in touch with you, Karen. I have some resources I can send you. The OSHA puts out actually a comprehensive list of all of the OSHA approved N95 masks and manufacturers. So I will, and if I can find it, I'll find a place to post it for anyone who wants to see it too. So I'm making myself notes here. Okay.
I can put all this stuff on the website, Amy.
Okay, great. Yeah, we'll figure out how to get all this information out there. Were volunteers with questionable lifestyle part of the approval process? Yeah, okay, so people who volunteered to be in the vaccination studies for efficacy were not asked to restrict their activities or to go about their lives any differently than they would have otherwise. And the reason people weren't kept under a strict protocol is because the importance of efficacy is knowing how it's, or trying to know as best as you can how it's going to work in the real world. So anyone who volunteered and qualified by medical standards was kept in the study. So some of those people might have been gallivanting all over town. Other people might have been in their own personal lockdown. It was a mix, and that's considered to be part of the randomization process. And then how might we know if we are in the 95% or 5%? Right. So, well, someone who gets COVID after vaccination would be in the 5%. I'm not sure. You can. We'll mute you. We'll unmute you in a minute, George, so you can, because I'm not certain I know how to answer your question. I'm not sure I understand it. Okay, Gail Black. Were the folks who were in the trial group, so they intentionally exposed to COVID? Was the exposure was random? So people in the vaccination groups, there was no intentional exposure. This was just people were giving their vaccinations or their placebo shots, and then they went about living their lives like they were going to live their lives. So again, the attempt is to try and get as close as we can to real world efficacy. What is this really going to mean for an average person getting their injection and living their lives under this current circumstance that we have? All right, can we unmute? Let's unmute George. Or how many do we have? We have 24 of us, or we might be able to unmute everybody.
Amy, I have a question that wasn't typed in.
Sure.
There was some news, or people were passing around verbally at least, that they heard that there were millions or tens of millions, maybe more, vaccines being held back by the government, but with no reason given. And I tried to explain that yes, they have to hold them back because you have to have enough supply for a second vaccination.
Right,
but
right.
They're insisting that they're holding back these vaccinations so for some unknown reason.
Yeah, no. What you said is accurate, Jim. It's and it has to do with a big piece of it now, especially that we have 3 vaccines, is we don't have any information about what happens if you mix and match. So for someone who gets their first Mrna dose, we need to make sure there is a second Mrna dose for that person, because that's their only option at that point. So and then the other piece of, well, why haven't we given all of the injections we've supposedly received? And the other piece of that has to do with distribution. So the government sends the vaccines out to the states, and then the states disperse them among the different centers there, and then it goes even further. They may give a bunch to Costco. Costco may then pass them out to several of their stores. So there are not any, as far as I'm aware, there are not any vaccines being held back for any reason other than to make sure that the people who need a second dose get their second dose of the correct vaccine. So.
Thank you.
Yeah, of course. Should we unmute? Have a free-for-all?
Yeah, people can unmute themselves.
I was wondering if Katie wanted to say anything from her.
Oh yeah, of course.
It's just, Dr. Amy, this was fantastic. I'm blown away.
Good information.
Good, I hope. I'm curious. I actually had a question for Katie. What are you doing out in the world? I know at work, of course, you have your N95 and tons of gear. What are you wearing out in the world?
I have an N95 that I wear if I'm out walking, just, like a random urban walk. I'll wear a surgical mask, and generally I don't wear it until I'm approaching somebody. And those of us who are out walking, it's a dance. You're coming towards somebody, and somebody will step into the street, and to avoid. So there's definitely social distance, just because it's a little more comfortable, and it's easy to go up and down. But I do like going to Fred's or whatever. I do wear an N95 in the hospital, whether you're an employee or a visitor or a vendor. As you come into the hospital, you're checked for symptoms, and they pass out a surgical mask. So, you know, it's better than nothing. The N95s are certainly better. And in the ICU, we will wear those. But, you know, walking around in the hospital, there's a lot of just surgical masks for sure. Yeah.
So there are few enough of us that I can see everybody. So we can actually just kind of wave and do hands. So George, let's do George, and then I've got Debbie up there. So George.
If we knew we were in the 5% unprotected group, we might behave differently. And some question is, could we get another vaccine, say from Pfizer, if our first one was Moderna? Kind of related questions, but
I'm not sure I understand you. So, well, the 5% is an after the fact. There's not a way to know preemptively. Just like if there's no way for me to read this, to me to be psychic and know the future if I'm going to be someone who gets sick or doesn't get sick, despite being vaccinated. So that's only known in hindsight. Does that make sense? Is that what you're talking about, George?
Well, is there some way to
you're in
know
the
if we're
5%?
protected? Is there any way to know if we're protected? How's that? Is that a better way? Question?
Well,
In other words, if your antibody
kinda
levels are
like-
high enough.
Oh, it's not. So yeah, an antibody test doesn't necessarily tell the whole story. This goes to some of those that detail that George was asking about T cells too. So there's not a way. And the other piece of this that I didn't put on a slide, but that's important, is a lot of what happens with COVID-19 is dose related, meaning if I'm exposed to a tsunami of COVID-19, I'm going to get sick with COVID-19. If I'm only exposed to a small amount of it, I'm much less likely to get sick. And the other piece of that is the amount that you're exposed to and that you take in also has an effect on how sick you get. So this is a place where the masks do make a big difference. You might still get COVID even though you've been wearing a mask, but if it protected you from half of the inflow that was coming in, you may have less serious disease with it. And I have friends who are a perfect example of this. There are a couple who are both in their early 80s who have been really faithful and diligent about masking and avoiding contact. And somehow, unknown to them, they did get COVID. Both of them had very mild cases, never needed the hospital, and had a complete recovery after just a couple weeks. So there's no way to know ahead of time if you're in, there's not a threshold. We don't have a magic number where once your antibody level is above a certain number. And the reason for that is that you don't always have antibodies circulating in your system. Some of it is your body's ability to create them and pump them out when needed. So that's why there's no way to have a blood test to see, oh, is my level high or low? It doesn't indicate exactly how robust your response would be in the moment if needed. Does that make sense?
Amy and George, the group. The other thing with the vaccine is, I think, George, your wording was like, can we, I'm not sure what you said, basically like relax your restrictions or,
Right.
But the vaccine is protective to the receiver of the vaccine, and it's still being teased out if it really is preventing spread to other people. And I think it is because you're, like Amy was saying, it's the numbers. If you have a lower amount of vaccine that of COVID that you're breathing out, that in itself lowers the chance that somebody else will get it. But it's still not clear that it totally makes me like unable to pass the vaccine on. So that's why, like, okay, you've got the vaccine, it's been 2 weeks, but if you're out in you still may need to wear a mask unless you're with other vaccinated people. Things are still being discovered about, what's going on with the vaccine and how it helps us.
Yeah. And then real quick, Debbie, I didn't want to miss Debbie. Debbie had a question.
Yeah, I typed it in, but I realized I typed it in wrong, so nobody read it.
Okay.
I don't know. I don't know what I did. Anyway, you said
ahead.
something about after the vaccine, that you between 14 days and 90 days after the vaccine, if you're exposed, you really wouldn't need to quarantine because you'd be safe. So does that mean after 90 days, it doesn't work anymore? That surprised me.
No, no.
Okay.
It's one of those situations where there's enough confidence that we kind of are certain to 90 days. And then the question is, how long does the immunity last? And some of it is just straight up, we can't know because nobody's been vaccinated for 90 days. Like we're only just reaching that point now. So that's the interval that people are willing to say confidently, yes, we know you're protected during this interval. I would expect that interval would extend as time goes on and we see how things are happening in the real world. Now on kind of the other side of that, I think because of the emergence of variants and the possibility that that might affect our immunity, I think there's a decent chance that no matter what vaccine you got, there may be boosters coming in the next 6+ months. So yeah, so we don't know yet, fundamentally because no one's been vaccinated that long. The study groups are continued to be followed. So some of them have been vaccinated that long, so they are being followed. But we just have to have a little more time to know what that time is, if that makes sense.
Okay, that one I typed. I had one other question that I didn't type.
Sure.
Just the now they're saying to wear 2 masks. So I've been wearing a surgical mask and the 3-layer cloth mask. How much safer is that then? You gave the percentages. Is that?
It's okay. So I'm wearing a surgical mask, which is with a cloth mask over. The important thing about masks is that they're really about fit and filtration. So the reason an N95 mask is so effective is that it has a tight fit that that doesn't allow air to get in or out. And I think the primary reason that cloth masks and other masks fail as much as they do is that they just aren't totally, attached to your face and adherent to your face. It's also really important that whatever mask you're wearing is one you can breathe through, because air will flow wherever it can flow, which means if you end up putting 2 or 3 layers on that you now can't breathe through, then all of the air is going to come around the mask. So adding a cloth mask can be helpful if it helps make the other mask more snug against your face. So that's what I do. I wear a surgical mask and then I wear a nice kind of firm cloth mask. One little test you can do is put on a pair of glasses or sunglasses once you're masked up. And if you're fogging, then you're having air leakage. So one tiny thing you can do if you want to is you can just put tape like you would put for a bandage and just put tape across your nose here. So doing those kinds of things and making sure it's fitting you snugly and it's actually covering your nose and covering your mouth are much more important than necessarily making sure you have, this particular N95 mask or.
I put metal strips on my cloth ones and my glasses still fog up no matter what.
Yeah, right, exactly. They still fog up. So you can do it. You can use little, if you want to be really safe, or if our numbers start getting crazy, you can get just a little bandage tape like you would use if you were putting a bandage on, and then just put the little tape across the top here, and that helps. So yeah. Or you can go N95. The prices are coming back down on them. They're a little easier to get and not as, hijacked as they were. I feel like I missed someone. Karen, yeah.
I know a lot of people here have grandkids and some also have kids, and they're doing this whole back to school thing.
Yes.
I personally would not send a kid back to school, but I'm wondering if there's any kind of, there's the official word, which is, yes, of course they can go back. But then what about the realities? Are they different?
Katie, do you want to start this one? This is a hard one.
Well, and I'm also working with student teachers who are going back into the classroom, and I need to decide whether I'm going to be going.
Yeah.
I think, there's, at the end of the day, one needs to feel safe and comfortable. So I am totally supportive if a teacher does not want to teach in person. Maybe they had the vaccine, maybe not. I would be supportive of that. It's so unfair to place that on put somebody in danger or what they perceive to be. And again, there's a lot we don't know. children are, they can spread it. They don't get
They
sick
can.
nearly as often or nearly as severely. So, I mean, do you send your kid to school and they have a cold and a stuffy, so that does, and that can spread too. So it's hard. And I'm kind of rambling, Karen, sorry. I think at the end of the day, I mean, and this is just an editorial statement. This has been a crazy year, and there's been a lot of, mental health and isolation and depression. And we've heard all about that. But I also want to feel like this has been a year for the children and the students. Hey, I'm resilient. I've come up with new strategies, new time management, whatever. And I know that's not the case for everybody, but as an opportunity to get not a positive, but to make this work. And maybe that still has to keep going a little bit longer, is like do hybrid, or I think more science is coming out. Like, is 6 feet really necessary? They're starting to look at 3 feet between people for safe distancing. And it's kind of a soft number. It's all about science. The CDC is actually studying, is 3 feet okay? And when they have enough data, they will say, you know what, 3 feet's okay. So that's going to open things up a little bit more, I think. And then there's just social pressure to open things up, and economic pressure, and that's hard to deal with too. It's but if we I love science. My profession is science and art, both, but I feel like you can't argue with science, and those numbers will support that. But at the end of the day, it's people, and we need to support the people and what they feel comfortable doing too. That totally didn't answer any questions. I just kind of had a little moment there. Sorry.
I'll chime in. No, I'll chime in with a little bit, kind of my take. The younger the child, sort of the less epidemiologic risk. So,
Yes.
Teenagers are very different from first graders. And I think it's really important for each of us as individuals to be mindful of kind of our own profile. Who are we? How high risk would we be if we got it? Have we been vaccinated or not? And like that. And so I can just share, for me, being someone who has an autoimmune condition, is immune suppressed constantly because of the medications I'm on. I personally don't socialize in people's homes with friends who have children under 3 that go to daycare, because I just know that is so risky for me to end up sick with something. So, I think all of us are going to have to be making some of those decisions, and it's harder for those of us who are higher risk. The other, maybe just for each of us making our decisions, what I would say too is, if you are fully vaccinated, it puts you back to sort of resets the clock and puts you back into like, okay, this is now cold and flu season, and this is what I'm dealing with. So it kind of takes what was, this horrible, scary monster COVID, and then kind of converts it to, okay, I might get flu, and there's a small chance that if I get flu, I could get seriously ill. So in terms of kind of what that looks like, or how you might manage that, I think that's a reasonable substitution to make in your head. Once you're vaccinated, that kind of puts you back to as if this were a noticeable flu season, a significant flu season. That helps. So it's hard to remember what it was like before, right? Like I have a dear friend who's a social worker who works in the juvenile justice system, and she has some bronchial issues herself, so she has to be careful about getting sick, and she's fully vaccinated, but it's just really hard for her to feel comfortable, kind of going back to all of the exposure and face-to-face interaction she used to be involved in so regularly. And I can understand that. So we didn't really answer the question, sorry.
But that's the situation,
Yeah, but if you're someone who's higher risk, I think caution. If in doubt, don't have the exposure. Would be my kind of overall advice.
So hypothetically speaking, if someone happened to be way overweight,
Yep.
And they have kids that might have started last week and this next week.
Yeah,
How high, I mean, I guess obesity and being overweight, how much
Yeah.
of a risk is that? And yeah.
Well, Katie might be able, Katie's gonna know.
Yeah, it
I'll know
is
more on that.
definitely a risk factor. And I think, I believe, I don't have it right in front of me, but I just in reading a journal, I think it's, you have like maybe 3 to 4 times the chance of getting COVID, getting seriously ill. And some other risk factors are kind of, they're together with being heavier, overweight, obese, whatever, that's a spectrum as well. Hypertension, diabetes. In the ICU, I think the big one, I'd say like 75% that are critically ill with COVID are obese. And again, hand in hand, the diabetes and hypertension.
Blood pressure.
You're being obese, you're always kind of at a low rate, you're kind of having a chronic inflammatory response, and things are always kind of cooking there ready to respond because it is a stress to your body. And so you have a whole lot of like extra pro-inflammatory mediators in your body and not enough of the anti-inflammatory. And COVID is a big, bad inflammatory disease. And that's where the trouble starts. So I don't know, Paulette, if that's answering your question. Yes, there's a higher risk, and that's kind of the why behind it. Yeah.
But it's important too for you to know that if your body mass index is 30 or higher, you're eligible for your vaccine March 29th. So
That's considered a risk factor.
You and I can get on the phone together.
Yeah.
If you're over 45.
If you're over
I'm
45.
49, so I'm
Yeah,
over 40.
Yeah. I saw a hand somewhere, but now I've forgotten where I thought. Was it Susan? Did someone else have a hand up about something? No.
I was interested,
Karen.
Katie, and Katie, what's your experience been, kind of along the trajectory of this? I can't imagine, I don't know anybody personally who's been in this situation, and I have so much admiration for what you've been doing. I would just love to hear about your experiences a little.
And it's a team sport all the way around. So I'm not a cog in the wheel, but a member of the team that has helped. Early on, Karen, just seeing New York and California and, mobile morgues outside and patients in the hallway, we were just like, we have to ramp up and be ready. And so early on, it was just like anticipating the big flood and the big wave to come in, which it wasn't a big wave, but it was a wave. It was smaller and it was tight and a lot of unknowns. People were like, they weren't accepting UPS boxes, and nurses were going home and showering in the garage with a hose and not going in to see their families, or not even living at home, because it was just like a real fear of transmitting it to their family members or getting it from the UPS box. Or so that was kind of wild early on, and people refused to take care of some of the COVID patients, which I understood. It's like, okay, that the whole unit can't do that, but certain people like, oh, I'm trying to get pregnant, or I am pregnant. And, there was things. So there's a lot of fear of the unknown and a lot of maybe, I think that was it. And there was fear. And then the patients kept coming, and it got tighter. And it's like the bed would not cool off before there was somebody else taking their place. And honestly, my particular unit has 24 beds. At the height, we had like 14 of them were COVID patients. But you know what? There's other people that have been in trauma or have had operations and things like that. And they kind of indirectly paid a price, but they needed care too. So it was like you had your regular population plus a population that was very much more labor intensive. wearing PPE and the PAPR helmets and layers of gowns and garb. You can't just run into the room if there's something going on with a COVID patient. They're in isolation, closed down, so you have to quickly don your gear, go in there, take care of them. So that was one. There was no quickness about it. The other piece is if they made it to the ICU or if they were admitted to the ICU with COVID, we gave them, this is how I view it, the best possible chance to survive, but many do not. If you're so sick that you're in the ICU, because there's really no treatment. There's supportive care, and we try to get them through that. And then the families, this breaks my heart. They can't come in if it's COVID positive. So there was a lot of phones to the ear or iPads doing FaceTime and saying goodbye. I'll start crying. It was very hard. And I felt bad for them, but it was hard for the staff too. But I will say, I mean, nobody in our particular unit was alone when they died. So that's a comfort. Probably the patient wasn't aware, but just to let the family know. Sorry, a little touchy. Yeah, tender spot for me.
Understandable. Yeah,
So
understandable.
In that, now the vaccines are out and things, the lid is off a little bit, is decompressing the pressure and the overarching, like, how long is this going on? It feels like there's hope and there's light at the end of the tunnel, and we don't have as many patients, and it's good. I'm very hopeful.
Yeah, I am.
Did that answer your question?
Yeah.
Thank you so much, Katie.
Yeah.
I was hoping to hear that there was some relief for you.
Yes. And again, we were pretty good. Thank you, Oregon. I mean, we're all essential to keep our mask and keep our hands washed and the distance. And that made a difference for us. Yeah. Thank you. Thank you all. Yeah.
Well, I think we're good. Jim, we can stop the recording. Yeah. Thank you, everybody. Thank you so much for your